Great. Hello, everyone. Welcome. We're super excited to have you all on. Thank you for spending your hour with us. My name is Michael DeSalvo Solarte. I am a program manager at the National Minority Quality Forum. We're super excited to welcome you all. The purpose of today's conversation is introducing you all to our joint partnership with NMQF and ABC called the Cardio Kidney Metabolic Disease Working Group. This is a recommitment and a reaffirmation of our longstanding partnership between the two organizations. So thank you for being with us. Can you jump to the next slide, Akia? So I just want to quickly go over today's agenda. We have a lot to cover, but we want to make sure we have time for discussion. But essentially, Kelly will get into introductions of NMQF. We'll then jump into a quick introduction with ABC. Following that, Kelly will introduce the purpose and the background of the working group. And then Dr. Underwood will give a presentation looking at CKMD disease. He'll give some statistics on that and talk about the disparities there. Following his presentation, we'll get into the goals for the working group for this year. We'll also talk about our main deliverable, which is called the Health Equity Framework. So Kalai will give a bunch of background into that. Following that, he'll continue the conversation talking about key areas of focus within the framework. Then Nisi will take it over. She'll talk about our working group structure, our subgroups within the working group. She'll also talk about our implementation timeline, what we have planned for this year. Then Akia will take over. She'll talk about how we'll communicate both internally and externally as a working group, how we'll share more about what we're doing and our findings. She'll also continue talking about our benefits. She'll lay out what you all will be offered if you decide to partner with us. And then finally, we'll get into some final remarks, call to action. We do want to reserve at least 10 minutes for discussion. So if you have any questions or you want to ask anything, please feel free to do so in the chat. We will save those for the last 10 or so minutes. But again, thank you all for joining us today. Thank you for spending your hour with us. And I'm going to toss it over to Kalai to continue the conversation.
Thank you, Michael. Hi, everyone. I see lots of friendly and familiar faces, so welcome again. Thank you for joining us. We are super excited to launch this initiative, which has a partnership between NMQF and ABC. So more to come on how we've come up with this initiative. But I want to provide a quick overview of NMQF. For those of you who may not be familiar, I know lots of you have worked with NMQF, are friends and partners with NMQF. So, briefly, the organization was founded in 1998. We've been around for over 2 decades, and we're focused on health research, data, education, and advocacy. So we have a mission to reduce patient risk and advance health equity, assuring optimal care for all. So this is very much aligned with this initiative that we're launching today. And then our vision is also to achieve a just and fair healthcare system so it ensures equitable and access to optimal care. We're obviously focused on underserved, underrepresented communities. We spend a lot of time thinking about how we cut down on disparities and the health inequities that exist, and thinking about how do we improve the health outcome. So with that, I'll go to the next slide and talk about the structure. So NMQF in the last 10 years have grown tremendously. And the way we're structured today is under 6 different centers, as well as the Office of the President. So we have I won't go into much details about each one of the centers that you see here listed in front of you, but 2 of the centers under the NMQF umbrella are going to be actively involved and part of the working group leads, and in addition to ABC. So I myself am vice president for the Center for Professional and Strategic Alliances, where can think of us as the hub for professional groups. So we work across disease states, fostering partnerships and collaboration across industry, academic institutions, working on joint initiatives to tackle health disparities. Uh, we've we have a number of initiatives under my center. One of the working group that would, I think, be worth mentioning here is we've done a cancer working group in which we have a number of partners from industry and patient advocacy organizations that coalesced to work on looking at the data, and seeing how we can collectively work to improve screening and education around cancer. So I'll mention that here and hand it off to my colleague, Akia Blue, who is the Vice President for Center and Sustainable Healthcare Quality and Equity. Thank you.
Good day, everyone. As Kalai just mentioned, I'm Akia. I run the Center for Sustainable Healthcare Quality and Equity, and our center focuses on quality improvement and community engagement. So we work with healthcare providers and health systems to help introduce techniques and strategies into their workflows to improve their care delivery. And then in terms of community engagement, we have a network of churches called our Faith Health Alliance, as well as our group of health champions, which includes barbers and stylists primarily, and we are expanding to include other entrepreneurs and small business owners. And collectively, these groups, we give them education, which they then take out into their community, to their congregations, their clients, and others to educate around a variety of different health topics. Under our center, we also have had the Diabetes Working Group, which has brought together members of industry, academic folks from the academic sector and nonprofit sector to talk about different topics related to diabetes. So we share our work, our projects, up and coming things that are relevant to diabetes, et cetera, all for the betterment of improving equity in diabetes care. And so we've invited members of the Diabetes Working Group to come and participate in this working group so that we can expand it and, not just only focus on diabetes in a silo, but be able to provide more comprehensive thoughts and outcomes. So at this time, I think we're going to move forward to turn it over to Cassandra.
Oh, great. Well, greetings, everyone. I'm Cassandra McCullough, the CEO for the Association of Black Cardiologists, and thank you for tuning in today. It's an honor to share ABC's journey and our mission to improve heart health, especially in communities that need it the most. So let me take a few minutes to walk you through who we are as an organization, what we do, and how we're making an impact. Next slide. The Association of Black Cardiologists was founded in 1974 to address disparities in cardiovascular health and to improve heart health for all. Our mission focuses on prevention and reduction of cardiovascular disease, including stroke, particularly focused in Black and minority populations while striving for optimal health for everyone. The need for our work is urgent, and I'll say that again. The need for our work is urgent. Black communities, as we all know, experience disproportionate burden or disproportionate rates of cardiovascular disease, kidney disease, metabolic disorders, and often more severe outcomes. These interconnected conditions highlight the critical importance of addressing health inequities as well as improving access to care. We achieve our mission through education, community engagement, research, advocacy, bridging those gaps between communities and providers to deliver meaningful impact. This commitment to reducing disparities or reducing barriers and improving outcomes has been central to our work for the past 5 decades. And this slide highlights ABC's 50 years as a trusted leader in addressing cardiovascular inequities, consistently advocating for and advancing health equity. Our membership is diverse, not just in race, but also in specialties as well as perspectives. It includes healthcare professionals, patients, corporate partners, academic institutions, and community organizations all working with us, all united around expanding public health education, addressing social factors that impact health, as well as advocating for policy change and supporting the next generation of leaders in the field. On this slide, you'll also see ABC's leadership team, myself, Dr. Anthony Fletcher, Dr. Paul Underwood, who's Dr. Anthony Fletcher, I'll go back, as president of the organization, Dr. Paul Underwood, chair of the ABC Board of Directors, and you'll hear from him a little bit later. And this slide focuses on the 4 pillars. ABC's work is guided by these pillars, and I will share a few points from each, without boring you with each bullet point. But in the area of research and innovation, we all know that Blacks are underrepresented in cardiovascular clinical trials, despite being disproportionately affected by heart disease. ABC works to close this gap by advocating for diverse representation. We support our members in leading research and, more importantly, in shaping clinical trial design. We believe that mentoring future researchers ensures that innovation does continue. In the area of education and workforce development, ABC has been an accredited provider of continuing medical education since 1995. We develop programs that foster excellence in healthcare, as well as prepare tomorrow's leaders. Ensuring representation and mentorship remains key to our workforce development efforts. In the area of community engagement, our flagship programs such as Spirit of the Heart, Community Health Advocate Training, We're the Faces of Black Maternal Health, and Family Heartbeats Unmasked focus on prevention, early detection, as well as disease management in underserved communities. Our outreach encourages intergenerational participation to drive lasting health behavior changes. In the area of advocacy and policy, Tammy Boyd leads this area, and we'll speak a little bit later on this, but I will say that ABC does champion policies that ensure access to affordable, high-quality cardiac care while addressing systemic factors impacting outcomes. So these pillars drive our efforts to advance equity as well as improve care and transfer cardiovascular health. So I'll say thank you for your attention. I hope this gives you a glimpse into ABC's mission and the incredible work that we've done, that we continue to do to ensure that every heart counts. So we, along with the National Minority Quality Forum, look forward to continuing this work together. Most importantly, with most of you here that's tuned in today. And with that said, I'll yield to our next presenters, Drs. Underwood, Tammy Boyd, and Nisi Johnson from the ABC team.
Great, thank you, Cassandra. This is a brief introduction. I'm Paul Underwood. I'm an interventional cardiologist, and I'm currently the chair of the board for the Association of Black Cardiologists. It's certainly a privilege to be here working with the National Minority Quality Forum on this very important project. Cardiovascular disease, particularly those caused by metabolic disorders, have really run rampant through our communities. And despite knowing about these issues for the past 2, 3, or 4 decades, we've been unable to control them. So it was very important that we link together, and certainly this is a significant linkage between the Association of Black Cardiologists and the National Minority Quality Forum. I'll now turn it over to Tammy Boyd.
Good afternoon, everyone. I'm Tammy Boyd. I'm Senior Vice President for Government Affairs and Strategic Alliances. Look forward to the conversation today, and I will be helping to lead the advocacy work group, which you'll hear later today. And I can turn it over to Nisi Johnson.
Good afternoon, everyone. I'm Nisi Johnson, and I'm the COO with the Association of Black Cardiologists. I am excited to be a part of this team, and for the past 20+ years working with the ABC to advance the work that we do and show impact not only in the community, but also with our professional education as well. So I look forward to sharing more about the work group and its structure later on in today's session. So with that, I'll give it back over to Caroline to introduce the team at NMQF.
Well,
Thank you so much. Yeah, Thank you so much. I believe you've heard from most of us already. So I'm Kelly Imru. I lead our team for Center for Professional Strategic Alliances. And then you have Michael as well.
Hi, everybody. I'm Michael DeSalvo Solarte. You saw me at the top, but I'm a program manager under our Center for Professional and Strategic Alliances at NMQF, and I work directly with COLI, so I manage a lot of the logistical aspects of this working group. It's great to be here. Akia?
Hello again, Akia Blue. I'm the president for the Center for Sustainable Healthcare Quality and Equity at NMQF.
Thank you. So we'll toss it to COLI for the next slide.
Yes. So this is a great introduction. You've heard a lot about how we've come together for this special initiative, but I want to start by highlighting this longstanding, strong partnership between NMQF and Association for Black Cardiology. So this was actually announced following our last summit. If you were at our last summit, you've heard the verbal announcement followed by the press release that went out in the beginning of May last year. Since then, this group, as well as others, have been meeting weekly to not only think about uh, how do we look at this issue in terms of the cardio kidney metabolic diseases, but how do we create a comprehensive program that looks at this issue that disproportionately impacts these underserved, underrepresented communities. So I'm super excited, and the group is thrilled to introduce this cardio kidney metabolic disease working group, which is the initiative that was born out of our partnership. So this is a collaboration that will bring and that brings together not only expertise and experiences of our collective organizations, but other colleagues like yourselves and different organizations around the table. So the effort is really aimed around uh, the shared commitment that we have to helping improve health outcome and then driving meaningful and measurable improvement so that we can move the needle with specific to CKMD outcomes in specific communities. So that's what we're here doing today. And we're inviting your organizations to help support this critical initiative by becoming sponsor and by joining us along this journey. So I will briefly mention the mission, as I said at the top of the program, aligns very well with both of our organizations in that it's a simple one, but impactful. It's to reduce disparities across cardiovascular, kidney, and metabolic health for underrepresented, underserved population. And we're going to do this by implementing looking at the data, so a data-driven, innovative, evidence-based solutions that can ensure optimal care and for all. So few core values we'd like to highlight for this specific initiative is number one, making measurable progress to reduce CKMD for this population, but also we are going to achieve this with the goal that we've laid out by activating our partnerships and conducting meaningful research, focusing on the clinical care. You'll hear more about that as well as on the policy side and the advocacy and engaging with the community through outreach as well. So we believe we can make a real tangible difference, and that's why this program is here. And I will turn this over to Dr. Underwood to talk to us about the background of CKMD and why it's such a big issue.
Great. Thanks, Caroline, for that introduction. And for the next few minutes, we're going to spend a little bit of time looking at the key aspects of CKMD and its impact and its consequences. So I think that all of us on the line here are very well aware of the challenges that CKMD poses. So cardio, kidney, metabolic diseases disproportionately affect racial and ethnic minorities. And so certainly both of our organizations have spent much time and effort in terms of awareness and education that we all understand this well. Just looking at some high-level statistics, Black individuals have a 20% higher risk of CKMD and are 2 to 4 times more likely to develop end-stage renal disease. And the list goes on and on and on, despite whatever therapeutic category we're looking at. And then certainly this brings up the point that we must address gaps in diagnosis, treatment, and follow-up care. This isn't a new entity. We have known that CKMD is going to be a problem and has been a persisting problem within the cardiovascular space for many, many years. And yet the treatments and the strategies that we have been employing so far have been ineffective in actually curtailing and reducing its impact. Can you go to the next slide, please? So just briefly, what is CKMD? I think we're aware that this syndrome, this metabolic syndrome, and how CKMD comes together is cardiovascular disease, as well as kidney disease and metabolic diseases, largely obesity and diabetes, how they form together, and they actually cause worse outcomes with the combination of these factors. Nearly every major organ system is affected as a consequence of the CKMD syndrome, and it has associated clinical challenges such as kidney failure, dementia, metabolic dysfunction, liver disease. Each of them has their own issue, but what it really results in is premature death and mortality. So a group of experts got together about a year ago and created guidelines and a framework for addressing the cardiometabolic syndrome here in the United States. And this was sponsored by the American College of Cardiology as well as the American Heart Association. And so they classified CKMD into 4 stages, essentially. The first stage, or I guess the 0 stage, would be people who have no risk factors at all. So looking at Life's Essential 8, they don't have their normal weight, don't have high blood pressure, don't have hyperlipidemia. However, the first stage are those people, typically those that have exogenous obesity. So excess adipose, dysfunctional adipose tissue. So obesity is the first stage. And the second stage would be those individuals who have other findings that go along with the syndrome, such as diabetes or insulin resistance, hypertension, hyperlipidemia. All right, and then it progresses to the point of, say, the 4th stage, which is heart failure, end-stage renal disease. And now what this means is that understanding that this classification is certainly broad at the beginning, that almost 90% of adults meet the criteria for some CKM syndrome, stage 1 or higher. We want to focus on those who are in the advanced stages, and only about 15% meet the criteria for those advanced stages of stage 3 and 4. The rates are significantly higher in the African American community, and oftentimes the ICD codes that are considered for these illnesses are looked at independently and not together, and therefore the aggregate may not give the entire spectrum of the impact of metabolic disease on Black populations because it's been split up. We're also very concerned that genetics and biology play only a small part in explaining why minoritized communities have a higher risk of cardio-kidney metabolic disease. And so in addition to the medications and the therapies that we have to offer, there are other factors that are interfering with our ability to actually control the disease. And just to get to the management, we do have many, many tools to use in terms of controlling the different aspects of the syndrome, whether it's insulin resistance and diabetes, obesity, high blood pressure, and certainly coronary artery disease. But we still have not been able to control the consequences of, say, amputation, sudden cardiac death, end-stage renal disease. And this is where we really want to have a lot of focus to understand why this is occurring and what can we do to keep this out of our community. Can you go to the next slide, please? So the shared risk factors compound the impact of cardio-kidney metabolic disease. So just looking down the left side, up to 50% of patients with diabetes are at risk for developing heart failure. About a third of adults with diabetes have also been diagnosed with chronic kidney disease. And chronic kidney disease is 3 times higher in patients with diabetes. As we move on around the circle, 60% of patients, or 2/3 of patients with chronic kidney disease, also have cardiovascular disease. And then over 60% of heart failure patients also have kidney disease. As we move on up, we see that cardiovascular disease causes about 2 out of 3 deaths in people with diabetes. The rate of hospitalization for heart failure is 4 times greater in patients with diabetes, and up to 45% of people with chronic heart failure have diabetes. And again, as I said before, these rates are significantly higher in Black and brown communities. Next slide. Moreover, patients with type 2 diabetes and cardiovascular disease have higher healthcare utilizations and costs. So the overall health costs are higher, so about $20,000 higher per person per year. Hospital and post-acute care costs are about 5 times higher. The number of people with hospitalizations are over 3 times higher. And the number of hospitalizations per 1,000 people is 5 times higher. So obviously, this is a major problem. Obesity and the downstream comorbid effects are associated with almost $500 billion in an annual direct healthcare cost and an additional $1.2 trillion in annual indirect costs related to lost economic productivity. And this uneven burden of the CKM syndrome in the population is a key driver of cardiovascular disparities. So what we've noticed is over time, we've done very well with cardiovascular disease in terms of reduction of mortality and morbidity for that matter. But we've come to a plateau. Since around 2011, the reductions have plateaued in some communities, particularly African-American communities. The cardiovascular disease rate has actually risen a little bit. And this trend has continued from 2011 to 2020, and it is largely underscored by cardiometabolic and kidney disease. Next slide, please. So the greatest consequence obviously comes to the patients. They're the ones that have the brunt of the impact of this, and this is by an impact on survival. So despite all the things that go on with people as they're being treated, whether they have claudication, angina, heart attacks, renal insufficiency, when it comes down to lifespan, these illnesses have a direct effect. So people who have severe obesity, defined as a BMI greater than 40, can have an 8 to 10 year reduction in their lifespan. Those people who are more obese usually have more progressive mortality, premature mortality. That was the first stage, if you recall, of the classification. The second stage was a diagnosis of diabetes. So going to the second stage, you'll have a 13 to 14 year reduction in your life. And we know already also that the earlier onset of diabetes has a greater survival reduction. And then skipping over to class 4, so end-stage renal disease, that has a tremendous impact. More than 20 years of lifespan reduction is associated with this. And so this is incredibly impactful for our communities. I just want to jump over to the right panel, and I like this for several reasons. It shows people with renal failure. So Blacks and African Americans are more than 3 times as likely, and Latinx individuals are 1.5 times more likely to have kidney failure compared to white Americans. And what this graph shows are, interestingly, that certainly the prevalence of, in the dark blue bars, the prevalence of kidney disease is higher in African American communities. It's seen on the left. In the middle are white communities, and so there's a marked drop there. And then on the very left, where it says overall, we can see that the high rate that's in African American communities does impact the rates overall for our country. Likewise, looking at the Medicare data for claims data, we can see that there are disparities there as well in terms of African Americans and whites who are actually getting care. What I think is very interesting with this, and it goes along with this, is that little bar, the dashed line that's on top of the Medicare, the light blue bars for the African Americans, which shows the impact of some of the algorithms for diagnosing and how that can impact people seeking care. And these are things that need to be identified so that we can bring them out so that people do have access to care and they're not systemic or algorithmic consequences that may indicate or negate the type of care that they get. It's clear that social drivers of healthcare factors such as racism, systemic inequalities, and lack of access are key to explaining the higher risk of cardiometabolic syndrome in minoritized communities. And that's why we want to join together to be able to make an impact on this. Before I turn it over to Kalala, I wanted to just focus on the next slide, which shows the impact of severe obesity and how it is spreading throughout our country. And I want to take particular note that those areas where it seems to be most severe also have high concentrations of African Americans. These facts underscore the pressing need to develop a framework for concise and direct actions to stave the continued spread of CKMD, particularly in disenfranchised and minoritized communities. This will not only preserve lives and families while curtailing negative economic consequences, to their personal finances and healthcare payers, but it will also reduce the consumption of this bad healthcare by the public, particularly when Americans are ranked with healthcare systems with other developed countries. And next, I'll turn the platform over to Caroline. Thank you.
Thank you so much, Dr. Underwood. This last slide was particularly alarming for me, just to see how incidence of severe obesity has shifted in the last 4 decades. Part of the reason why we're here today and trying to make an impact, and which is, so you'll see on this slide, we've laid out the goals for 2025. Now, on the outset, you'll see the degree of difficulty is high, but we can collectively do something about it. So our goals, as highlighted in front of you, is to begin with the research, to begin canvassing on the issue, and to support insights, innovations for healthcare around CKMD. So we'll look at how do we reduce the prevalence of lowering CKMD incidences in these communities that we're discussing, where the rates are alarming. And we're looking to promote outcomes and help improve outcomes, and identifying these and addressing the social conditions that we know drive these rates. So we know that there's certain social drivers of health that are connected to not improving, but increasing the risk of patients in certain communities. So we'll look at that as well. But the goal here is to also help improve access through advocacy. So it's going to be touching on all of these angles, and then working through outreach with the community directly. So building that trust and establishing the credibility to make sure we're educating and empowering the communities to roll up their sleeves and participate in this. So next slide, please. So the framework, the CKMD Health Equity Framework, that is the overall output. So with this working group, what we're hoping to do is once we've done the work, the output is to provide a comprehensive guide on improving care across these metabolic diseases. So across cardiovascular, kidney, as well as metabolic diseases, and how to help improve that in these communities. So the key areas, as I mentioned before, is going to be looking at community engagement, the advocacy. The data is going to be every part of this, from looking at diagnosis to prevalence to screening rates, literacy across the board, as well as the clinical practice. You'll hear more about this in detail, but the purpose really here is to look at what actionable insights and recommendations can be made with strategies for this to be executed, so we can actually achieve our goal of reducing CKMD risk in patients. Yes, so we're going to start here. So how will that be done? What is the strategy? What will we exactly do? I mentioned the data is going to be huge, and I want to quickly say, for those who are not familiar with NMQF, we've been collecting data for over a decade, and we have over 5 billion, yes, 5 billion patient records that we've collected over time, and it's mainly focused on Medicare and Medicaid. So we're able to look at where the disease prevalence is, but we're also able to look at costs and outcomes through looking at the data around ER visits and hospitalizations. And we now have a data library for social drivers of health that sits on a separate platform, but we can analyze those to see exactly where the gap is in these communities, and then come up with actionable insights through the working of with a working group. So that will be the data. We'll have obviously some guardrails with access to the data, but we have through CMS, the chronic condition warehouse, or the master's patient summary file, which will have all of these chronic conditions that are in cardiovascular, kidney, and metabolic diseases. So I'm super excited to look at the data because I don't think much has been done in that area, and this would be very complementary to what we're going to do with the community engagement and then the advocacy and the clinical side as well to make some actionable recommendations through the framework. So with that, I'll hand it off to my colleague Akia to tell you more about the community engagement piece.
Thank you, Kalilai. Yes, so we will include in the framework best practices for reaching the community. And, we very much value the importance of trusted voices. And that is why we have networks like the Faith Health Alliance and the Health Champions, because they are leaders within their community. And so we're able to tap into them to help us determine the best resources for their communities, the best messages for their community, because everything we want to do, we want to ensure is culturally sensitive and appropriate, and to make sure that it's the best way to reach the people that we're trying to reach. And so we'll use our community networks to help us develop the best practices for reaching them and the best messages as well. And so I'll let Tammy speak to the advocacy and clinical pieces.
And thank you, Akia. So 2 key areas of focus, as you see, is clinical practice and advocacy. First, starting with the clinical practice area, we would utilize ABC's network of physicians and expertise in CKMD care, coupled and along with NMQF's access to patient networks. Again, this framework will really provide a detailed guidance on disease-specific education, provider, and also provider education. And this is really designed to incorporate culturally competent clinical protocols in care delivery tailored to, as mentioned, minoritized and underrepresented populations in CKMD care delivery. And the next area of focus is around advocacy. This group will focus on policy recommendations for reducing disparities in CKMD care access. ABC, as you may know, is a leading authority for policymakers on issues that impact the practice of and access to cardiovascular care in all populations, including by advocating for initiatives and programs focused on education, prevention, and treatment. ABC and NMQF's expertise will be utilized to guide policy recommendations within the framework. And then just for example, advocacy work group will identify congressional and regulatory issues, bills, and asks. The group would also discuss opportunities to comment on existing proposals, preparing messaging documents, which include backgrounders, fact sheets, talking points, and which is really an important need to empower the CKMD advocacy group, the members, as well as advocates, to really take our message and request to Congress and administration. And so the advocacy work group also seeks to create a process by which members can bring CKMD policy issues to for consideration and coordinated action. And the goal is to ensure that members are well equipped to weigh in on CKMD issues at the federal, state, and local levels, policy discussions and/or events. And so with that, I will turn it over to Nisi.
Thank you so much for that, Tammy. So how does the working group structure really look? So we are looking to engage a diverse group of persons as representing CBOs, our community networks, advocacy groups, professional societies, industry, and others to help frame a group that can talk about and work on all of the activities that we've shared so far. We look to subdivide the overall working group into smaller subgroups, focusing on cardiovascular disease, chronic kidney disease, and metabolic disorders. And we anticipate that those groups will meet, subgroups will meet at least monthly, and the full group will come together on a quarterly basis to make certain that we are moving the needle and making certain that we are realizing the goals that we've outlined for 2025. So we will provide regular updates, and we want to make certain that there are key milestones and deliverables throughout the year. So in the next slide, it kind of depicts what our timeline will look like. Starting obviously with Q1, where we are now, is about doing things what we're doing right now, sharing the information about the working groups and soliciting those who are interested in being engaged and wanting to introduce the overall concept to the public. That will help us happen during the first quarter of this year. And the second quarter of the year, we're hoping to kick off more formalized meetings, start having meetings with the subgroups to get them started with the monthly activity. And then, as you can see in third and fourth quarter, we really start to roll up the sleeves and develop the framework that we can look to have published by the end of the year, realizing the goal of making certain that we have an evidence-based solution for the community engagement, advocacy, and the health equity work that we're hoping to do to really address the issues around CKMD. So with that, we'll turn it back over to the colleague to talk about our next steps.
Thank you, Nisi. And so just quickly, of course, we will be communicating. This opportunity offers the chance for networking, engaging, and sharing our outcomes, our thoughts out publicly as well. So we will be promoting the initiatives, engaging with stakeholders, and using things like webinars and LinkedIn and other social media platforms to do so. Of course, making sure that we all know the sponsors that are involved, as well as the outcomes that come out of it, to make, ensure that we are sharing the messaging, the learnings, and everything far and wide. And if we get into the sponsor benefits, so there are the 4 areas: data sharing, of course, the community engagement, the education for healthcare providers, and then advocacy. And we did just speak to all of these, but we just want to make sure we're highlighting them. And what I want to spend just a couple of minutes going through, I know we're at time and we want to, almost at time, and we want to make sure we have time for questions and discussion. But we do have different levels for sponsors to come in at. And so starting with the bronze level, these are the things that would be available for anybody who sponsors at bronze, silver, or gold level. I'm not going to go through and read all of these. We can certainly discuss them more and follow-up calls with you each. But of course, there'll be brand visibility. We would have at the bronze level, you'll be able to have a representative for each of the quarterly meetings, as well as one representative in one of the 3 subgroups, and that's something that will change with each group or each level as we go up. There are other various access to different materials and reports, data levels that are involved at the bronze level. And then if we move up to silver sponsorship level, you get everything that was in bronze, but additionally, some few items, and including you get 2 representatives in the quarterly meetings. And so then you also have a representative in 2 of the 3 subgroups. And then similarly, if we move up to the gold level, you get everything that was in the first 2 levels. And this one, you would have 3 representatives in the quarterly meetings, 1 representative for each of the subgroups, and some additional access to data and participation with our community groups, et cetera. So of course, more benefits at the higher levels. And so I'm going to turn it over to Dr. Underwood to bring us home with the conclusion.
Great. So thank you very much. So in conclusion, the collective experience and expertise of ABC and the National Minority Quality Forum, we've joined together, and the opportunity is there for us to synergistically work together. I know that we've worked with many of you together, many of you on the call individually, but now we have the opportunity to join together and work synergistically. So we'll have the clinical expertise that ABC brings, as well as the data and the data management and the community networks with the National Minority Quality Forum. This framework design will support and halt further spread and limit the current damage from cardiovascular and renal metabolic disease, particularly in minoritized communities. And this working group brings together like-minded experts, including physicians, community partners, researchers, and industry, to collectively combat disparities and expand access to needed cardio-kidney metabolic care in underserved communities. This will also provide data that will help guide our understanding of these diseases, and particularly identify any gaps and understand where we need to improve education and access for our patients, as well as design better clinical pathways and other policy measures that may improve the health of communities, particularly as it relates to cardiometabolic disease. So we're asking for your support to build a framework designed to contain and control this crisis before it continues to do further damage to people, their families, and their collective economy. So part of the call to action will be to be part of a transformative initiative to advance health equity, and please join us as a sponsor and contribute to lasting change in CKMD care. I think with this, we can go on to the questions, the question and answer session, and the floor is open.
maybe we start to see, is there any questions that came through on the chat, Michael?
No. Mm-mm.
All right, so we're either very crystal clear or clear as mud, one of the two.
And
Any questions? Anyone has any thoughts, questions, or comments?
just a reminder, we will
Hey
send.
y'all, this is Zachary Hermes, based in Boston. Um, just want to say, couldn't be more excited that this group is being brought together and formed. It is a crisis, in every sense. I have been trying to evangelize kind of within my system and my spheres of influence. So I'm really excited to be able to work and contribute to this group, and I'm grateful for the platform and the infrastructure it's creating. So thank y'all for the leadership.
Thank you, Zach. We look forward to working with you and couldn't agree more with your comments. Any other questions or comments? I'll give folks a few, maybe a couple more minutes to see if there's any questions. But in the meantime, since we do have a few more minutes at least, I want to just talk about our plan for how we will structure and facilitate these working groups. So I think it's worth mentioning we'll have a large CKMD working group. That's the point of this initiative, but we'll break out into 3 subgroups, as Nisi mentioned during her discussion on the slide. So the cadence we're planning for meetings is, at least at the initial kickoff, will be at our annual summit. If you haven't been there, I encourage you to go. The meeting link for registration should already be out. It's the last week of April, I believe, and Michael can probably put those dates in there. So we're hoping to kick off and officially launch in April, and then we'll have another in-person meeting, hopefully before end of the year, at potentially the ABC's summit. So the purpose is to work in those subgroups, consolidate the work from these monthly meetings, and then we'll come together and align on our objectives and the different sections of the draft for the framework. So yeah, it'll of course be hybrid, and it will be sensitive to people who may not be able to show up in person for those 2 meetings. Everything else will be virtual. But during the monthly meetings, so there'll be subgroup meetings with monthly, and then we'll focus on specific topics, but we'll all work on the same topics. For example, have diagnosis, screening protocol, and treatment access and outcome that's focused on the 3 subgroups that are aligned in CKMD. So cardiovascular, you'll have the chronic kidney disease, and then diabetes metabolic area in one. So these subgroups will work separately, but then come together once a quarter, and then we'll report our progress, and that's how we hope to facilitate it. So just wanted to clarify that, and then more details will be available, made available to you before we launch. Any questions, comments? See, let me check any questions that came in on the Q&A chat.
But thank you, Melanie, for your comment. We very much appreciate it.
Yeah, I'll maybe ask a question since there's open air time. I guess what have been the reflections that have led the kind of framework to be oriented around the disease states, for lack of a better word, versus the kind of action areas, meaning kind of organizing around cardiovascular disease, CKD, and metabolic versus orienting around data, clinical practice, community engagement, and advocacy. I think one of the things that's been interesting to me about the CKM construct has been its ability to avoid kind of the fragmentation around organ systems that have often undermined kind of coherent action on these deeply interrelated conditions. So that's the only place where the conversation, I mean, the question comes from.
Mm-hmm. Right. So from a clinical perspective, I see that, just as you said, it's disease oriented. With allopathic medicine, as we have it here in the United States, is very disease focused. So cardiovascular disease and endocrinologic disease or renal disease. And so that does segment things. As I mentioned earlier, the ICD-10 codes are typically segmented and they're not grouped together. And so you see it as one disease and one illness, and we'll work on this, and then go to the next doctor and you'll work on another disease and another illness. And so there's a pressing need. The biology, so the way the medicines and the treatments work, is pretty consistent amongst people. The genetic factors some are there, but not overwhelmingly so. So our inability to control this entity is likely based on things that are not necessarily biologic, and they may more relate to the social space. And groups have not looked, particularly physician groups, are very clinically oriented, looking at, data for treatments that guide making guidelines for guideline-directed medical therapies. But that is only touching the tip of the iceberg for what this problem actually is. And so we need to look a little bit deeper, peel the onion a little bit more to see what social constructs are underlying these persistent disparities and inequities in both the prevalence of the disease as well as the poor outcomes of individuals with this combination of illnesses.
Thank you for answering that, Dr. Underwood. So, and Zach, I'll add by saying, at least from NMQF standpoint, we looked at the data and continue to be alarmed and concerned about the disparities that exist within each one of these disease states. Obviously, there's a lot of overlap, as Dr. Underwood, as you mentioned as well. But in us coming together, one of our goals was, what is it that we can do collectively, lending our experiences and expertise to make a dent, move the needle around an area that we know is a big concern. And so we talked about different initiatives and different ideas that's focused, but the idea that approached, or the idea that came forth, was to address these, since they're so closely aligned and a lot of overlap in between these. So the data is concerning, and when you look at chronic kidney disease, cardiovascular disease, diabetes, and metabolic disease. So this one collective working group, we're hoping will be the best option for us to address, at least.
No, that makes a ton of sense. I think what I've been really working to do in the clinical front is try to actually build models oriented around the stages, right? Stage 2, stage 3, stage 4, right? Because I think, just as we're all getting at, these are biologically and physically largely the same process, right? That manifests first and consequently, in different ways, in ways we don't fully understand why somebody gets endothelial dysfunction first and another person gets, insulin resistance, or so on and so forth. So that makes sense. I think the point it came at the front of my mind was, I think, right, like food is medicine, is really central, right, across kind of the disease states. So that's I think one of the things I'm really excited for us to talk about. I think as it's coming online, I'd be really excited for the group to think about advocacy around food as medicine, as really a clinically indicated therapy, versus there also needing to be the hurdle of extreme poverty or extreme financial insecurity. But the idea that food as medicine is part of GDMT, right? So I'm done with my tangent. As y'all can tell, I'm very excited. So
Thank you.
Thank you for your comments, Zach. And again, couldn't agree more. There's so many issues we could tackle, but they're all interrelated. So Do you see any other questions in the chat, Michael?
Not, but we have 2 minutes. So you have anyone else want to ask anything, please feel free. I also put my email in the chat. So following today's call, I will send out the recording and I will also send out the presentation that you saw on your screen. But if you have any further questions once we end the call, please feel free to contact me. My email is on the screen. My number is there as well. It's also in the chat. So I will be your go-to person for now. If you have any questions or are interested in partnering with us or want another presentation for your colleagues, I'd be happy to set that up for you all.
Well, thank you so much. Just as a closing thought, I'll say again, I think we have a huge potential to make a tangible difference, especially in the patients that need it most in the communities that we work with. So I'm happy and excited that we can work together to make this, optimal health, not just a goal, but a reality, and to move, and we can move the needle together. So thank you all so much. Please be on the lookout for our follow-up. And see you all in April if you can make it to our summit. Take care.
Thank you. Take care.
Thank you.
Thank you.
Bye.
Thank you.
Goodbye.